Good morning, everyone. So we will be starting our IC on MIGS, minimally invasive glaucoma surgeries in India. Why, what, when, and how. So glaucoma, as you know, is a complex disease, and it was always considered a medical disease first. And surgery was no, the only surgery available was trabeculectomy, and then other surgeries came up, and MIGS is been on the edge for a long time, and now it is the time to start MIGS. So let's, without any further ado, start with an introduction to MIGS, and then we will go on to see uh, all the different types of MIGS that is available in India: Bang, KDB, and Tenito Hook if you know where to get it, and GAT, iStent, and iStent Inject. So I'll start with an introduction to MIGS.
A brief introduction about Dr. John. He is the chief instructor of this course, and he's a practicing glaucoma surgeon at West End Eye Hospital and Chaitanya Hospital. Uh, Jonda will talk about introduction to MIGS and then about intraoperative gonioscopy and 3D printed learning. Over to you, John.
Thank you, Mahesh, for the kind introduction. So I would like to thank KSOS for inviting us for this IC once again. Last year also we had done an IC on MIGS, and it was well appreciated. So without further ado, I am starting with the topic. So MIGS, micro-invasive or minimally invasive glaucoma surgery. Sometimes it is called minimally effective glaucoma surgery by some people, but it is not. According to all practical experience, we are seeing that there is adequate pressure control for mild to moderate glaucoma. Special thanks to Prasanna Venkatesh Ramesh for videos for this presentation. So MIGS, we have mostly an ab interno approach, and we do minimal disruption of anatomy. That is the main USP of MIGS. So we do MIGS, we always have an option to do trabeculectomy later. And efficacy, it may be less efficacious in some cases, but sometimes it is efficacious enough for the patient, and it has a high safety profile. That is another major advantage, and it has an ease of use once you get over the learning curve. So why MIGS? It's a very good question, and I'll just tell you what patients are ideal for MIGS. So most people tell you that it is a mild to moderate glaucoma. POAG, that is open angles, pseudo exfoliation or pigmentary glaucoma, all these respond very well. Sometimes in severe glaucoma, you can do it to reduce the pressure if trabeculectomy is not feasible at the time. Cupping of less than 0.8 is what is suggested by the manufacturers and all that. Pre-op IOP up to 30 millimeters on medications. We target IOP of 15, and phakic or pseudophakic, both are fine. You might want to do the cataract surgery first and then put pilocarpine to constrict the pupil and then go ahead for the MIGS. And many of the indications are patients who have a difficulty in taking medication, either because of any other difficulties or side effects, poor compliance to the medication, and patients who would benefit from a reduction of IOP or medication, number of medications. And it is essential to have a normal angle anatomy, so you have to do a good gonioscopy pre-op, and there should be no peripheral angiocyanic EA, rubiosis, or any other angle abnormalities. So which MIGS that we will see in the following talks, because there are a lot of MIGS available, starting from all the implants that includes the iStent family, the Hydrus, Cypass, Solex Gold, Zen, PresserFlow. All these are implants which you place there, and the trabecular bypass MIGS, where you just do a bypass of the trabecular meshwork, basically deroof the Schlem's canal to some extent. That can be the affordable low cost bag, and the more effective KDB and GAT and suture GAT, trabectome, and HFDS, which is available on some machines. So they have no financial interest. I think the Earthly machine has high frequency deep sclerectomy. Yes. And then ab interno canaloplasty was in favor quite some time back. Tanito microhook is another angle procedure, another instrument, and streamline is another one. So these are some of the ones which are available here. So that is the Cahook dual blade here and the iStent injector with the iStent inside. And the most important skill to start with is intraoperative gonioscopy. So you need to have practice this. You need to have a direct gonio lens, and you can practice with a Sinskey hook. You put a cohesive viscoelastic. So sodium hyalurate 1.6% is what you need to use, and you use that. You use a direct gonio prism such as a Swan Jacob gonio prism. This is a autoclavable glass type one. You can also use the more expensive but more stable TVG lens, which allows you to fixate the globe as well. And then you have the disposable ones, and there are also the hands-free ones. So there is the Catena hands-free lens, the Ocular Secure Flex lens, and the iPrism SX. These are essentially, they'll stay on the cornea without holding. You will need to adjust the position occasionally, but it is makes the surgery more convenient. So this is the iPrism SX that you see over here, and this is the Cahook dual blade. And then this is another one, which is the Oculus Gonio-Ready lens, which is attached to the microscope itself. So that is another option for a lens. And here Dr. Prasanna will show you how to position. So positioning the microscope and the patient is an essential thing to learn. So you need to tilt the microscope around 30 to 45 degrees, and you need to find the angle at which it is best seen and mark the position. And then you need to tilt the oculars also. So you need a microscope which allows you to tilt the body and a tiltable oculars to do MIGS comfortably. So so that's what we saw. It is advisable to put a mark like this on the tiltable part of the microscope so that you can ask the staff to easily put it there. And then this is how you position the patient. So tilt the microscope and tilt the patient. So you tilt the patient away from you. And sometimes visualization is bad because the tilt is not adequate. So you tilt the patient a little more, tilt the microscope a little more, and then you have to visualize. So one tip is to keep the patient's head above the heart, and that will reduce the blood in the Schlem's canal. And that is one of the difficulties during the surgery, that you might get a blood reflex into the anterior chamber and obscure the vision. And this is another lens which can be used. So this is how you put the cohesive viscoelastic, and you put the lens on top, and then you need to be also comfortable with fine focusing the microscope with your foot pedal. So these are all the technical things that you will need. You will need a microscope which can tilt the body, tilt oculars, and has a good fine focus, because you will need to be fine focusing to get a good visualization while you are in the anterior chamber. So just make sure that you have the necessary equipment, because not all microscopes have all these things. So this is how you go with the Sinskey hook and practice going. And this is the same video. So this is the iPrism SX, which will just stay stable like this as long as you put a good cohesive viscoelastic. So that is also possible. And I think this is for GAT that is making. And to practice surgeries, you will definitely need the small instruments, but to get a better understanding, you can definitely use these 3D printed models. And also you can use these 3D models in your PowerPoint presentation. So if you see, you can download these models from my Thingiverse website or the National Institute of Health website. These are 3D models here, and these are the 3D printed versions of those. And you can even use an app called Object Merge app, and then you can move around the 3D models in virtual space with just a target cube. This is just an A4 sheet paper which is printed, and essentially once you put the cube and look at it with your phone, you can load any 3D model on that. So this is a teaching tool for us, as well as if you want to show the patients that this is the sort of implant which will be put, because these are new surgeries. Patients may not be very comfortable starting a new thing, so you can just use these as teaching tools. Thank you, and I would like to hand over to the next speaker. I'll end with this. Thank you. So next, we will have Dr. Neetu Mohan. She is the head of glaucoma services at Arvind Eye Hospital, Chennai, and she is a very, very sweet person. She is very happy to teach everybody, and I would like to say that she needs no introduction, but she is doing a lot of MIGS procedures of different types, and I'll hand over to Madam for this talk.
So good morning. So it's going to be just a few of us. So any clarifications, any doubts, I hope we can stop and clarify any time and discuss. So this is regarding the early surgeries which you can probably attempt as you start your MIGS journey. So KDB, bang and Tenito microhook in our experience have been the easiest to learn when we started. And we all have been doing MIGS only for the past 2 years. So it's been a learning process for all of us. So the first question that even today morning that I heard is, should I do MIGS at all? So I am honestly a very conservative surgeon. So I also had this doubt for quite some time. So what is for MIGS? Yes, in most of our patients, we get about 20 to 30% reduction in intraocular pressure. And till what we have seen now, there is definitely some decrease in medication burden. Shorter surgical time, sutureless. Post-operative day one, patients are very happy as far as ocular comfort is concerned. Vision is another aspect altogether. And we always needed some options for our high myopes, patients with a high cylinder, elderly patients whom you could not put through a trabeculectomy. So this is one option that we have now. And toric IOLs, again, probably can be combined with MIGS. We have started a few cases now. So that is an option that we have now. And what really tilted the balance for me is that these surgical techniques are definitely going to evolve. If not in the form that we are practicing now, MIGS is going to stay in some form of or the other in the years to come. So it makes sense to learn the techniques and also teach the people who are going to carry this further, so that in future we are not left behind. And yes, there are problems when you start doing MIGS. We still do not know the long-term outcomes. The longest follow-up that we have now in literature is only 4 years for GAT. Beyond that, we do not know. Post-op day one, patients are not going to be happy with vision. Almost everybody has some amount of hyphema. You will have to counsel the patient preoperatively. Cost is an issue, and there is still a lot of lack of clarity about the protocols, preoperative and postoperative. So we are all learning as we go. But I have been advising MIGS till now, and what initially I was quite hesitant, like when I tell patients that we have this new surgery, we are not sure whether we'll be able to take you off medications. You are on 3 medications now, you are 70 plus. We don't want to do a surgery with sutures on you. So we have this option. Do you want to take it? You are on 3 medications. Post-operatively, we hope you will be on 1 medication. And surprisingly, most of them want that option. Like they are all dependent on somebody else to put drops for them. They are buying medications lifelong. So surprisingly, patients were more accepting than I was. So now I do offer this for at least for all open angle glaucomas which have a definite field defect and are on 1 or more medications. I do offer this and I leave it to the patient. So for those who are still in doubt, you may want to think about this. And this chart has been going around quite often now. So as we can see, in the past few years, there has been a drastic change in the trend of surgeries which are done in the US. So there are more and more of MIGS happening in the past few years. So we definitely need to learn the technique. So I'll be talking about Kahoot dual blade, bang and Tenito microhook, all of which, as John has already explained, address the resistance at the level of the trabecular meshwork. And of course, they are ideally to be done in mild to moderate open angle glaucomas on 1 or 2 anti-glaucoma medications. It is a good option for patients with drug intolerance and poor compliance. Aqueous outflow dynamics, we know that the maximum resistance to the flow of aqueous is at the juxtacanalicular trabecular meshwork and the inner wall of the endothelium of the Schlemm's canal, and this is what is going to be addressed by the surgery. And it is important to look for the episcleral venous fluid wave after surgery, since this, if present, tells you that this patient may do well following MIGS. It shows that the aqueous channels are patent. So the Kahoot dual blade is a handheld knife which is designed to engage, stretch and excise a strip of the trabecular meshwork, and this is designed to remove the trabecular meshwork with minimal damage to the collateral tissue. So the distal tip, as you can see, it pierces the trabecular meshwork, and once it engages it, you can feel it sitting into the Schlemm's canal. And the trabecular meshwork gets elevated into these ramps over here. And after that, as you cut, the width of the blade is similar to that of the trabecular meshwork, so you end up doing an excisional goniotomy. So the positioning of the patient has already been described, and it doesn't happen in one go, one turn, 35 degree to that side. And of course, it is good to have the 35 degrees, 35 and 45 degrees marked on the microscope so that you can do it quickly. But it doesn't immediately happen when you tilt the patient that way and tilt the microscope this way. You may still have to ask your assistant to move a little more that side or little more towards you, the patient's head, so that you get a really good en-face view. That can be done within, like you can take about 2 to 3 minutes to position the patient well and get a good en-face view. We tend to do it after cataract surgery, except in toric IOLs. Now we are considering whether we should be always doing it before cataract surgery, because we don't want to leave viscoelastic in the anterior chamber. That is still, the protocol is not yet clear as far as we are concerned. We use intracameral pyloamine and use a clear corneal wound from the cataract surgery. This has already been described, so we'll skip this. And tip of the KDB pierces the trabecular meshwork, and you advance it. In these 3 techniques are what we have. The first is mark and meet, where you plan your extent of excisional goniotomy. You mark the further aspect where you are going to end the goniotomy. You mark that point there, go in, enter into the Schlemm's canal there, and then start from the opposite side as far as you can go and move the blade towards the point where you have marked. You can also do outside in or inside out. So these 3 approaches are available for Kahoot dual blade. We use a Ketina lens. So it can be ETO'd and reused. We have been using the same few lenses for the past 2 years. So this is mark and meet. So I'm marking the end point and then starting from the opposite side. This is a heavily pigmented trabecular meshwork, so the trabecular meshwork is very well visualized. This is one of the earlier, probably the earliest KDB guide goniotomy that I did. So I don't work with this much zoom now, but at that time I wanted to be sure that I am at the right plane. So you can see the trabecular meshwork being stripped or excised there. You can see the strip of the trabecular meshwork. Though I had marked it there, it didn't really come off like that, so I had to go and complete the goniotomy. And following which I removed it with a capsule forceps. So this is the postoperative view of the cleft, goniotomy cleft. So this study, which compared phaco KDB versus KDB alone, found that in phaco KDB group, about 71% of the patients achieved a success criteria, which is reduction of at least 20% of the IOP from baseline, or reduction of at least 1 glaucoma medication, and about 68% in the KDB alone group achieved the same criteria. Whereas there is this RCT which compared KDB phaco versus phaco and found that though there was a difference between both the groups, IOP control was better in the KDB with phaco group, this difference was not statistically significant in this RCT. But there are retrospective studies comparing phaco KDB to phaco iStent which have found similar results, and now we have the systematic review and meta-analysis published recently, which is of 26 studies and 1,600 plus patients, and they found a definite difference between phaco and KDB phaco, where the mean IOP reduction is at least 20% plus, and there is a definite drop in mean anti-glaucoma medications when compared to phaco emulsification alone. So now we hopefully have some definite evidence that there is a definite reduction in intraocular pressure. Bang is again a good surgery to start with. A 25 gauge needle can be used, and the very distal part of it can be bent to 80 degree. It eventually looks similar to a KDB or a Teneto hook. And it is important to know that it is to be bent the reverse of how we do in a cystitome. The bevel is you bend towards the bevel so that the smooth surface is what faces the outer wall of the Schlemm's canal, so that you don't damage the outer wall of the Schlemm's canal. So you bend it the reverse of how you do for a capsulotomy. And this width of the double blade is also titratable. Depending upon how much width you want, you can decide to bend at that point. But I agree it is not as comfortable as the other techniques. It is quite a sharp instrument. And as soon as you go in, but this happens in almost every case, as soon as you go in, there is some amount of bleeding from the Schlemm's canal. But the technique is essentially the same. So there is no RCT or prospective studies on Bang, but there are retrospective studies which have had similar results. That is about 20% reduction in intraocular pressure in about 70% of the patients. So this is a very comfortable instrument in our hands at least, but as John said, it is difficult to get this in India right now. So this does incisional goniotomy, not excisional goniotomy, and this is a micro hook. This is the Teneto's micro hook. The advantage is you can get a wider extent of trabeculotomy because this is a set of 3 hooks where the straight hook is meant for the nasal angle, and you have these right-angled and left-angled hooks which is meant for the inferotemporal angle. So the straight hook is used for the nasal angle, and then we have these left-angled and right-angled hook with which we can do a goniotomy if you want to in the inferotemporal angles. So you get a larger goniotomy with this technique. So,
We have time, ma'am. We can continue.
So this is a Teneto micro hook. This is a straight hook meant for the nasal angle. So it's a very handy small instrument, and the main advantage which I find is that even when it is in the Schlemm's canal, since it is so shiny, you are able to visualize where it is, and it feels similar to a Sinski, so we are very familiar with the feel of it. And this is the inside out technique that I am doing, and as expected there is some bleeding from the Schlemm's canal. And as much of the extent that I can get from the temporal aspect, I do a nasal goniotomy. Inferior I have tried, but it is not as comfortable as doing a nasal goniotomy. So there are quite a few studies on the outcomes of Teneto microhook. This is by Teneto himself, and they found actually better results. But we do not know in Indian patients, we don't really know the outcomes. They have found a mean IOP reduction of about 31%. And 69% of the patients achieved IOP control of less than 18 millimeters of mercury. And they have also compared it with suture GAT and found comparable results. And this is an RCT from Aravind Eye Hospital, Tirunelveli by Dr. Devendra. And they found a definite IOP reduction when compared to microlot with phacoemulsification. Compared to phacoemulsification, they found that microlot had very good outcomes. They found a mean IOP reduction of 51% from baseline. So the complications expected in any of these surgeries, as mentioned earlier, hyphema is the commonest complication. The patients will have to be counseled prior to surgery that they will have some drop in vision for the first 1 or 2 weeks post-operatively. There can also be iridodialysis, iris shafting. You are working very close to the ciliary body and to the decimates. So there can be complications related to that. There can be transient elevations in intraocular pressure, and resurgeries may be required for hyphema. Toric IOLs in MIGS, there are just very few publications on this. This is one recent one from Tenito himself. So they have combined MIGS, the microhook trabeculotomy with toric IOLs and found good results. As expected, the technique did not seem to interfere with the placement of a toric IOL, but it's a very small sample size. We still do not know the long-term outcomes, but it is probably a possibility in our patients with very high cylinders. And from the same group, there is this publication which compared trabeculectomy, expression, ab externo trabeculotomy, and microhook trabeculotomy. So what is interesting is that the MIGS procedures, of course, as expected, has very little surgical induced astigmatism. So it is possible to combine these procedures with toric IOLs in patients who really require that. So my few cents on this. So definitely this is an option which we should probably provide for our patients with mild to moderate glaucoma, especially in elderly patients with multiple comorbidities who cannot go through a longer surgery. Patients should be counseled on realistic expectations and postoperative hyphemas, which are very frequent. Anticoagulants need to be stopped 5 to 7 days preoperatively. Techniques are very similar. Though in our hands, we have found KDB glide and Tenito hook to be more predictable than bang. Intracameral pilocarpine helps in visualization, especially in crowded angles. It is good to have a phaco incision exactly at 9 and 3 o'clock rather than a little inferior or a little superior so that you can approach a nasal angle directly. Good visibility is key. Give a subtenon block without much of subconjunctival hemorrhage and bleeding. Have a good phaco clear corneal incision. Get used to the microscope foot pedal control. Once, we all started using the microscope foot pedal when we started doing MIGS, and now we are not able to do phaco also without the foot pedal, because once you start using it, you realize how comfortable it is to have it. And keep zooming in and out when you introduce instruments and when you try to visualize the angle. Use whatever zoom that you are comfortable with. And use a cohesive viscoelastic like Orogel or Helon, and do a thorough AC wash in the end. And this probably, there is not much of clarity on this, but most of the surgeons use a cohesive viscoelastic to do a 30% to 50% fill of the anterior chamber at the end of surgery. So you can use any of the cohesive viscoelastic. We use Orogel Plus, but not a dispersive viscoelastic like Viscoat. So this is what we generally do. We do a thorough wash after MIGS, we do a thorough wash of the anterior chamber. We sort of wait till the active bleeding stops. And once a thorough wash is done, put a little bit of Orogel at the center in the visual axis, about 30% fill. The globe is still soft at the end of this. You do not fill the chamber. See, the globe is still soft. And then with saline, gently form the chamber so that the cohesive viscoelastic stays in the visual axis. So maybe this will not affect the long-term outcomes of the surgery, but even if you have a bleed, it looks something like this. You'll have a bleed in the periphery, and the patient will not have an alarming post-op day one with a hand movements vision, where even a little bit of blood, when it is dispersed, it causes a very drastic drop in vision, and it is very difficult to explain to one-night patients and patients with advanced glaucoma. So again, literature is limited by the small sample size, narrow spectrum of glaucomatous disease and conflicts of interest. We have to wait and see how these techniques evolve, and more evidence is awaited. Thank you.
Thank you so much, ma'am, for that informative talk on all these different MIGS procedures. And you have inspired us to all start doing MIGS. We will have a discussion at the end. So right now, let's go to Just Got to Do It by Dr. Mahesh. Dr. Mahesh is a consultant glaucoma surgeon at Ahilya Eye Hospital, Palakkad. And he did his UG and PG from JIPMER and fellowship from LV Prasad Eye Institute. And he has a lot of experience in MIGS. Over to you, Dr. Mahesh.
Thank you, Jonda, for the intro. Thank you, KSOS, for the opportunity. So, after discussing about intraoperative gonioscopy and all the trabecular cleavage procedures, which are limited to 120 degrees, I am here to talk about something which we can achieve almost 360 degrees trabecular cleavage. So, this is about gonioscopy assisted transluminal trabeculotomy, or GAT. So I will be talking about what, when, how, and why. So the what of the GAT is about the introduction to the world of MIGS and about the GAT. And intraoperative gonioscopy, Dr. John has already spoken. The disadvantage of talking third is, like, especially in MIGS, all the procedures to start, only the devices are different. The intraoperative steps, how to do gonioscopy, how to adjust microscope would have been already covered by the previous speakers. So, as John already showed, MIGS was described in 2012, almost 12 years back, and minimal trauma to the target tissue, faster operating time, modest efficacy, high safety profile, and rapid recovery. This is what we have at present with us, the whole of glaucoma surgery armamentarium. And on the left hand side, we have the MIGS, and I'll be talking mainly about the GAT procedure. So GAT was developed by Dr. Devinder Grover and his team at the Glaucoma Associates of Texas. It's a non-bleb forming MIGS procedure where the Schlemm's canal is de-roofed, and it's a conjunctiva sparing ab interno 360-degree trabeculotomy. It was started as a illuminated catheter-based trabeculotomy, and they do that still, and in resource-limited setting, and we can also do it based on 50 Prolene suture. So both the speakers spoke about the microscope rotation. What I can add to it is this app, which is available on the App Store, and you have the equivalent apps in Android also, where you can place the when you measure the angle. So it's always difficult to keep measuring it every time. So you measure the angle of 45 degrees, mark it, and then once you have marked it with a permanent marker, it's going to be there forever. And next time you don't have to, keep measuring it again and again. Since all the procedures are trabecular meshwork based, how to identify them? Obviously, by the grade of pigmentation. If you have a patient like pigment dispersion syndrome or a PXF glaucoma, where the trab meshwork is heavily pigmented, you don't have much difficulty. Then you can do something called as a provocative gonioscopy and force the reflux of blood into the Schlemm's canal. And you can induce hypotony or a reverse Trendelenburg position. Dr. John mentioned about having the head above the heart so that you don't get much of blood while you are operating. But to visualize, we can give a reverse Trendelenburg position and keep the head below the heart level so that you induce some amount of reflex blood into the trab meshwork and into the Schlemm's canal and visualize the trab meshwork. And also, staining the trab meshwork with trypan blue also helps. Now, going into the when, how, and why of GAT, we have patient selection, pre-op evaluation, surgical procedure, and advantages of this procedure over the others is what we will be discussing. Patient selection, more or less, is the same what we have discussed. We should have a cooperative patient, and patient who, since most of the procedure deals with tilting the head of the patient, you don't want to have a patient who has a cervical spine problem. The indications as such is mild to moderate glaucoma, but if you look at the innovators, Dr. Grover et al. And his studies, they do it in quite severe glaucoma also. And the amount of IOP reduction, what they claim is around almost 30 to 40%. But if you are going to begin your surgeries, you can better do it in primary and secondary open angle glaucoma. You can do it either standalone or with cataract extraction. Better to start with patients where controlled IOP on 2 medications. Preoperative gonioscopy is an absolute must in the office. And then practice few sessions of intra-op gonio in routine cataract cases. So here we have a routine cataract case. At the end of it, you just have to put your gonio lens onto the cornea after putting the viscoelastic. Take a Sinskey hook, go visualize the You can see that nice red blood in the Schlemm's canal, which is the trap meshwork, and the so if you can see here, this is the trap meshwork behind which is the Schlemm's canal. There's a roof, and then you have the scleral spur, then you have the ciliary body band or the root of iris. So you just need to go take your Sinskey hook and touch the Schlemm's canal. And practice the motion, which we do it in either KDB or bang procedure or a tornado hook. So in combination with cataract extraction, we need to get a detailed consent. As we already discussed, the visual outcome will be a little bit delayed as against a cataract extraction alone. So you need to discuss this with the patient and have to get a detailed consent. Then discuss recovery delay and discuss the head positioning. When done standalone, pilocarpine drops 15 minutes prior to the surgery gives a nice constriction of the pupil and quite allows you to visualize the angle. Now, which to be done first? As Dr. Neetu said, like when she's doing toric or studies say that, you better do the procedure first and then do later. But when you are doing a MIGS in a normal case where you have glaucoma, if you feel that cataract is there, and then the cataract is quite significant and that your cataract surgery might induce some amount of corneal edema, which might, later hamper your visualization of the angle, better to do the procedure first. Do the rexis so that you don't, when you're intraoperatively, you don't touch the ALC and have problems with your rexis. So do the rexis, then fill the angle, fill the anterior chamber with viscoelastic, do the MIGS procedure, then finish up your cataract surgery. By doing this at the end of the cataract surgery, after IOL placement, you don't even have to wash the viscoelastic because that visco is anyways going to remain there for tamponade. So this is a study which said that there appears to be no significant angle visualization difference whether the surgeon chooses to complete the angle surgery before or after phacoemulsification. Therefore, the decision should rely on the surgeon preference. Intraoperatively, positioning as against the phaco, where the elbows are at sides, you are sitting straight and you are operating at a coaxial light. MIGS is arms straight, and you are doing a procedure where your one hand is extraocular and one hand is manipulating intraocularly, and there's a little bit of increased distance between where you are sitting and where you are going to be operating because of the microscope tilt. So this is the cluster of instruments that is currently being used when we do a trabeculectomy. And as against that, look at the amount of instruments that you need when you're going to do a GAT procedure. There is so much decluttering. All you need is 2.8 millimeter keratome to create the incision, and then you have the MVR blade, and then you have irrigation aspiration cannula, a direct gonio lens. This is what we have, the Grieshaber forceps, what they use for ILM peeling. You can have this. So this is what the forceps which we'll use to grasp the suture, Prolene suture intraocularly to pass the suture all along the trabecular meshwork. And then you have the 50 Prolene. So 50 Prolene, when it comes with the needle. And then as of now, we don't have the pre-tip made 50 Prolene available. So you just need to show it as close as possible to the cautery. This is a normal bipolar wet field cautery, and the tip of the suture will become bulbous like this. So you need to have something similar to this mushroom, which is a small mushroom. You don't need such a big mushroom which will, bypass the size of the Schlemm's canal. So I'll just show you once again. You don't even need to touch it. The only problem is most often, I think it's a universal problem, your cauteries don't work. And if you have a situation like where your cautery is not working, you can also have a flame in which you can heat up your either iris reposter or a spatula, and then show that heated spatula close to the suture. That will also make the tip bulbous. About the gonioscopy, few tips that I would tell is don't put the viscoelastic on the cornea. Put the viscoelastic on the lower surface of the lens, so that you don't have viscoelastic spreading all over the cornea. Because when you have created incision, suppose you have nicked some corneal blood vessel, that blood when mixes with that viscoelastic will hamper your view. So put viscoelastic sufficient amount on the back surface of your gonial lens and just use that. Depending upon the eye and depending upon your dexterity, you can rest your hand on the malar prominence or on the forehead. Then, when you are visualizing the angle with the gonio lens, don't use the gonio lens to, look at the angle. Now you are visualizing that nasal angle. You want to go a little bit infronasal or supranasal. Don't use the gonio lens to tilt. Ask the patient to tilt, or you rotate your position, because by tilting the gonial lens on the cornea, you are going to put pressure, induce corneal folds, which is going to hamper the visualization. Then zoom into the desired area. So this is the intraop visualization of the nasal angle. A few tips about the wound construction. Avoid the limbal vasculature. A 2.2 millimeter incision is sufficient. A temporal incision is what we do to access the nasal angle, because most of the collector channels are available in the infranasal quadrant. A tangential incision for the suture entry. I'll discuss about this in the surgical video. I already spoke about the advantage of intracameral pilocarpine. Then about the suture and forceps introduction into the AC. So we introduce the suture into the anterior chamber first. Then we introduce the Grishaber forceps into the anterior chamber. And then we put the lens. Because if you put the lens on top of the cornea and then start to introduce your suture or your forceps, because of refraction, there is a different in the level. What you see and what you are actually going to put, you might hit on the cornea, you might hit on the, if you're doing a standalone case, you might hit on the ALC and cause ALC trauma. If you see reflex heme, keep the eye firm by injecting viscoelastic. At the end of the surgery, half fill of the anterior chamber with ISCO or the air tamponade is what we desire. So here is a procedure. So you see the angulation of the MVR. This is what I told, tangential incision. By this tangential incision, so the surgery has been done. This is the clear corneal incision for the cataract surgery. Through this incision is what we are going to introduce our suture holding forceps, and this is the nasal angle. So by tangential entry like this, our suture will come and sit in this nasal angle. If you have the usual straight entry like what we do it in our cataract surgery or SICS, what happens is the suture comes in the center. Taking this suture from this center here to the nasal angle will create a kink in the suture, and that kink will not let you allow passing the suture smoothly. And there's a voiceover to this. Can you have the voice, please? You see how இதுல வருது. It's okay. So we have placed the suture inside. We are avoiding the limbal blood vessels. This was one of the very initial cases. So once you visualize the angle, you should be, the practice gonioscopy helps because you don't need to put pressure on the cornea to create these folds. When you have these folds, it's going to hamper your visualization. Then you take the MVR blade, go to the nasal angle, create a goniotomy. A successful goniotomy will have a little amount of reflex heme and a nice white background. That's the Schlem's canal. And then you have the suture, and we are holding the suture with the Grishaber forceps. We need to pass it along. And then once it's gone into the Schlem's canal, you just need to, thread it. It takes around 25 to 30 strokes of threading to get the suture all throughout. And every time you pass, there will be little bit amount of blood. Every time you see blood, please fill the anterior chamber with viscoelastic. And the first time you get that suture traveling 360-degree and coming back will be a wow moment when you will see the umbrella tip coming back. So it has gone and come back. And once it has come, you just hold it with the Grishaber forceps, the intra ocular part, and the outside one, you just hold it with the McPherson forceps, and then you rip. When you rip it apart, it just travels a complete 360 degrees. So this is at the end of the surgery, this is a different case. What I want you to see is this quadrant. You saw the blanch. You saw this, see this blanch. See the blood vessels here. This is what Dr. Neetu had spoken about, the episcleral fluid wave. So when you tighten the anterior chamber, fill, you see this completely blanching. This is showing the patency of the collector channels. This is another case of silicone oil filled eye post VR surgery glaucoma patient with 4 medications. Patient was actually planned for a AGV. Intraoperative gonioscopy showed a open angle. Then we went ahead and did a 360-degree GAT procedure. At the end of the surgery, after 3 months, you can see the nice cleavage all around 360-degree, and the patient continues to be on only one medication now and well-controlled IOP at the end of 3 years of follow-up. So post-operative follow-up, hyphema is expected. Like Dr. Neetu told, we need to fill the anterior chamber and fill the center so that the hyphema does not impair the blood visual acuity. What again we add on is we ask the patient to sleep with head end elevation so that the blood settles down. Initial post-op day IOP may be high. And depending on the severity of the glaucoma, it's the surgeon's choice, surgeon's call to continue the anti-glaucoma medications, step down one by one. At 1 week post-op, we change over to low-potent steroids or NSAIDs. Role of pilocarpine was, it's a debatable this thing. During the COVID, when there was no pilocarpine available, we still did procedures and we somehow managed the patients without pilocarpine. So at some point, if you feel that there is a small PAS, because you're creating raw surface, the iris tends to go towards the raw surface. If you feel that there is at some point a small PAS is developing, it's good to add pilocarpine. Advantages as against the other procedures, it achieves a 360-degree trabeculotomy. It's a cost-effective conjunctiva sparing. Mind you, all the procedures that we talk about is some time down the lane, you might need a trabeculectomy. You just want to postpone the time period, whether you give the patient a 2 years, 3 years, 5 years time for that trab to happen. That's all the idea of managing glaucoma itself. We keep on giving medication so that we don't want to do a trabeculectomy. Now we have SLT so that you postpone for 2 more years. Now you have MIGS, again another 2 to 3 years you postpone. It has a learning curve. It's steep, but it's short. Currently, MIGS, how much IOP decrease, how long, what's the cost, is it available to us? Yes. What we had a couple of years back and what we have today, we have a lot more options available. It's easy to learn. Finally, my take clinic message would be patient selection is the key. Intraop gonioscopy plays a major role. About the procedure specific, tangential stab entry into the cornea to access the nasal angle. Avoid limbal blood vessels. In standalone cases, intracameral pilocarpine can constrict the pupil and help visualization. Achieving an adequate size of the mushroom tip of the suture. And finally, practice, practice, and practice. Thank you.
Thank you, Dr. Mahesh, for that insightful talk. And last, we will have Dr. Prasanna Venkatesh Ramesh's talk on iStent Inject, and the MIGS glaucomas. Unfortunately, he couldn't be here in person. So he'll be presenting from the metaverse or glaucoverse, as he likes to call it.
And I'm Dr. Prasanna Venkatesh Ramesh. We'll be talking about these three and taking you into the Glaucoverse dry lab as well.
So from the metaverse, Dr. Prasanna Venkatesh.
Thank you, KSOS and John sir, for giving me this opportunity to talk on MIGS, not all the MIGS. We are going to speak separately on these three stenting devices. And I'm Dr. Prasanna Venkatesh Ramesh. We'll be talking about these three and taking you into the Glaucoverse dry lab as well. So, the three stenting devices are the iStent, iStent Inject, and the Inject W that you can see behind me. I started my journey in the World Glaucoma Congress in 2019, where you can see me doing the iStent as well as the Hydras on top. And this is a journey that I'm still learning and I'm updating. As you can see, the WGC from Italy. So this is something which is very novel and coming into the armamentarium of glaucoma surgery. And my talk is going to be from my publication in the IGO February 2023 issue, where I'll be talking about the three stenting devices of MIGS. So the patient selection criteria, make sure you start slow and steady with a mild glaucomatous patient, POAG, then slowly move to a moderate POAG and whatnot. So make sure you select your patient with a CE ratio of 0.6 or a 0.7 or P25 millimeters, then slowly you can maybe go to the higher IOPs. So I use CDT lens, the Tansen Volt Gonio lens, as well as the IC66, no financial disclosure here. Let's start with iStent Generation 1, the G1 series. So, the procedural journey. So, this is the glide, the ideal implantation that one needs to do. So once you have oriented the anatomy in your mind, make sure you take the stent and tangential placement is done into the pigmented trabecular meshwork, and in this case, once the stent was placed, I was able to see a beautiful vessel perfusion in the collector channel, suggesting that it was in the right plane and the vessels are perfused. So the cheese wiring, so it has its own fair share of learning curve. So in this you can see the first attempt, second attempt, third attempt, there was a lot of cheese wiring that was happening, and only finally in the fourth attempt I was able to, understand how cheesy the trabecular meshwork was before I could place the stent. Another thing that you would have to cross in your journey is the knife. So once the stent has been placed, if there is extensive, bleeding, or you are not able to identify whether it is in the right plane or not, it is one step that I advocate for neophyte drive, take a sensitive hook, it's the look of iris driving down. So when you do that, if you are able to visualize the scleral square, then you are in the right plane, and that is the plane of the pigmented trabecular meshwork. That really works well if you are not fully able to get an in-fast view and if there are more of IC or pigment dispersion. So reform. So what happens in this, if you see in this particular scenario, I am trying to place my generational one stent. So when I am trying to place it, what happens here, if you see, when I am removing it, the stent is also trying to come along with the broker, or you see the stent just, hangs like a sinking ship. So again, when I am trying to grasp it and then place it in, again when I am trying to, open the claws, when I am opening the claws, see what happens here, just trying to come and finally I have to take it, I had to then choose a different location, and then this time a controlled release works. And you can see a slow motion controlled release of the stent was there. And also make sure your left hand on the gonio is not compressing. Sometimes that also will cause these kind of implantation. So here again the stent tried, to come out. If you can see here, it's still trying to come out, but the polarity of the coming out was counteracted with the slowness of the movement, and that made sure that all is well and well. So, in advanced cases or maybe moderate cases, if you feel along with a stent, you need to do a gonectomy or with a KDD or a bag. So, this is again a combined MIGSMinimally. You can see combined stenting procedures followed by a KDD on either side 2 clock hours away. Similarly, you can also use a band. So once the stent is placed, you can also combine a bent arm internodal gonectomy on either side where you can, open up the trabecula meshwork so that if you feel an additive IOP loading is needed, combination of 2 MIGS procedures could also help in this purpose. So the results are very promising in literature. We have also done our own study, which I'll be sharing. Another scenario, again, this is one of my the patients where a PhD was used, and the surgery was well on track. Everything went on very smooth. I had to slightly extend the rexus opening, but at the end of the IOL implantation, all was smooth. So I tilted the microscope towards me, patient said away from me, and then when I took the stent trocar, I was seeing to my surprise the stent was actually missing. So it was there in the box and I had to align and grasp it again. So see this movement, my dear. Can see the polarity of how it ripples. It's just a size of it is just like a fingerprint. So it's very, very important to take a stent that has been dropped, especially in the outside. And then once you have learned that, I think you'll be able to manage that, and then all will and well, the stent was placed very well in the angle that you can see here, and this patient is doing well. IOP is rotates with angular imaging. Generation 2 moving to I-stent injector, the G2 series, moving from a tangential implantation, now moving into an axial one. So I give a dimple and then implant the stent by a shoot or a trigger. Then after 2 clock hours, the second stent is implanted, and between the 2 implantation, you can see there is a paralimbal blanching, suggesting that the tissue is actually telling us it's in the right plane and the procedure has already started to occur. Lost but found. Definitely you will have your fair share of complications, as you can see here. Superficial implantation of a stent. What happens when you use a superviscous fluid like a Gilon flow? It just fill back. Don't panic. It's just going to stand there. So make sure you place the second stent first by giving a much bigger dimple. And once you have done that, and then try to retrieve it and place it. So in this case, I just thought I'll come out, take a breath, and then go back in. So when I was trying to come out, right, I failed to close the trocar, and I again lost it. You can see again a heart in the mouth moment where I lost the stent again. So to my luck, it was just there, the TECO wound. So the TECO message was always you close your trocar when you take the stent out. So I had to go back and take the stent, then again went in and then implanted it. So all is well and well. So these are some of the videos which I didn't have much of learning videos during the time when I started. With the benefit of neophytes, I felt these simple tips and tricks will be really helpful. So PECO I-stent analysis,
So due to shortage of time, I'll skip over this part, and we can take any questions. So this is about the analysis and all that. And the Glaucoma is basically a few apps which Dr. Prasanna has, which you can download on the Play Store. So I'll give you the links for the apps later. And yeah, we can take any questions regarding MIGS. Anybody who wants to start MIGS or who has just started MIGS, any questions? Any common questions that, any common FAQs that you have come across, ma'am, Dr. Mahesh?
Nothing much. Only thing is the main learning point for GAT which I had was this tangential side port, because we are always taught to make side port towards the center of the cornea. For a long time, I was wondering why goniotomy is happening as I was introducing the suture, which is when I realized it is a very thick suture, so you can't really bend and take it there. It has to naturally lie in a way that it points towards the point where you're going to start the goniotomy that he demonstrated very well.
I think like all of us said, patient selection and pre-operative and intraoperative practice gonioscopy. This is the most important, I think, take-home message from this session would be. And then with respect to each individual instrument, just goes ahead with that. Thank you.
Thanks everyone. And if we have no more questions, we'll hand over to the next IC. Hope all of you are now ready to start MIGS.